And certainly want to welcome everybody to this week's happy hour. Just by way of announcements and logistics, I'll be doing the session next week. The week after, which is the, let's see, that would be the 7th of September, we won't be having a session in observance of Labor Day. And then we'll pick up again September 14th. And September 14th, one of my colleagues at Sagis Diagnostics, Dr. Raj Myrmecial, is a derm-trained dermatopathologist, and he's going to be giving a talk on life after residency. So for people who are getting ready to graduate, I think it'll be a real good talk. He's taught for a while, has been in academics, and also was in the private practice of dermatology for a while. As well, so it's a really good talk. I think it'll be one that you'll want to attend. And we're just thrilled to have Dr. Vandergriff hosting our session today. By way of introduction, Dr. Vandergriff is an associate professor of dermatology at UT Southwestern, and he's got a joint appointment in the Department of Pathology as well, and serves as the Robert G. Freeman and Clay J. Cockrell Chair in Dermatopathology. Dr. Vandergriff is board certified in dermatology and dermatopathology, and he directs the UT Southwestern Dermpath services. He's been awarded the Derm Department's Outstanding Teacher Award and has been recognized by his peers as an upcoming leader in the field. And he's co-authored several textbooks and published numerous peer-reviewed articles. Travis also served in a teaching role and has been a course director at several AAD courses and has served as faculty in a number of regional and national meetings. And it's with great pleasure that I introduce my friend and colleague, Dr. Travis Vandergriff. Travis, thank you.
Thank you, Tom, for the introduction, and thank you also for the invitation to participate today. I'm really excited about the session and looking forward to it. So I'm going to share my screen, and let's see. Okay. Can everybody see the screen with the slides on it?
Yes, looks good.
Okay, great. Okay, so I'm going to go through the unknown slides today, and you'll probably notice a little bit of thematic similarities between some of the diagnoses. The first couple of slides, I think through number 5, have what I would say as the common theme here is the superficial perivascular dermatitis differential, and also kind of touching on the differential diagnosis of vacuolar interface dermatitis. And so I'm going to try to share some of the tips that I use in making these differentials and highlight some of the classic textbook features that would be expected to be seen in each one of these diagnoses. So this first biopsy, it's a punched biopsy. And as we move in on a higher magnification, you can see that there's a perivascular infiltrate, which consists mostly of lymphocytes. And you can tell that they're lymphocytes at scanning magnification because they have a dark blue color. If you were dealing with histiocytes, you would be seeing a more pale infiltrate. And then neutrophils and eosinophils usually have a little bit more of a pink color on scanning. So just right off the bat on scanning magnification, you can see that you've got a superficial perivascular lymphocytic infiltrate. And there's also this concentration of lymphocytes in the upper part of the dermis, in the papillary dermis. Now, it's sort of up to the individual viewer to decide if they would call this a lichenoid band. A lichenoid band of inflammation is, technically speaking, a band that abuts and obscures the junction. So I wouldn't use the word lichenoid, but I would certainly recognize that there's a patchy band-like infiltrate in the superficial part of the dermis. But I wouldn't use the term lichenoid since I don't think it meets the full criteria for that. And also, lichenoid is a separate differential microscopically than the vacuolar subtype of interface dermatitis. So as we go on higher magnification, we can start to see that there is indeed vacuolar interface dermatitis here. So the major reaction pattern for this biopsy is interface dermatitis, vacuolar type. And by that, I mean interface dermatitis without a superimposed lichenoid band. And what I teach the residents at UT Southwestern to look for when vacuolar interface dermatitis is the potential reaction pattern is to look for vacuoles or holes that have been punched into the basement membrane, making the junction between the epidermis and the dermis indistinct. So instead of seeing a nice sharp line between the epidermis and the dermis, we see holes or vacuoles that have been punched into that space, making that junction sort of blurry. But there's no superimposed band of inflammatory cells to obscure it. Also, the other kind of key feature of vacuolar interface dermatitis is the presence of dyskeratotic keratinocytes in the epidermis. So here in this field, I see dyskeratotic keratinocytes in the basal layer and in the spinous layer. And a dyskeratotic keratinocyte is simply a synonym for apoptotic or individually necrotic keratinocyte. And you recognize it because a dyskeratotic keratinocyte has condensed, brightly eosinophilic cytoplasm and a shrunken hyperchromatic nucleus. It's called a pycnotic nucleus. So these cells here in the basal and spinous layer that have that bright eosinophilic cytoplasm and the small hyperchromatic nucleus are dyskeratotic keratinocytes. So we have vacuolar interface dermatitis. And the next thing that I try to determine is, does this look like a process that's more acute or more chronic? And the features that I look at to make that determination are the cornified layer and then the silhouette of the epidermis. So notice in this case that the cornified layer is basket weave orthokeratosis. No parakeratosis, no compact ortho hyperkeratosis, just normal basket weave ortho. That is an acute cornified layer. Notice also that the reedy ridges retain their silhouette. We still have a undulating pattern here with up and down reedy ridges interdigitating with dermal papillae. In contrast, in the more chronic eruptions, you'll have effacement of the reedy ridges and the epidermis becomes flat. So this is, again, a silhouette more consistent with acute vacuolar interface dermatitis. Cornified layer supports that interpretation. And that differential is more suited for erythema multiforme and fixed drug eruption than a more chronic eruption such as dermatomyositis or cutaneous lupus. So DM and lupus also have interface dermatitis, vacuolar type, as the reaction pattern, but they've got more chronic changes. So now we kind of focus on that differential of erythema multiforme and fixed drug eruption. I should also mention on that differential diagnosis, acute graft versus host disease, which really, to make that diagnosis, you need some clinical information, either about the history or at least some laboratory values, because acute graft versus host disease, for all intents and purposes, exactly resembles erythema multiforme. So I kind of consider those two to be histological twins. So we have here the dyskeratotic keratinocyte, the superficial perivascular infiltrate. And then what I look for next is in the dermis. And so what I see here are melanophages. So histiocytes that have melanin granules in their cytoplasm. And then I see a numerous infiltrate of eosinophils as well. So these eosinophils are these cells that have granular eosinophilic or red cytoplasm and a bilobed nucleus. So even in this field here, I can see 5 or 6 eosinophils and multiple melanophages. So the melanophages are indicative of repetitive episodes. And that is the hallmark of fixed drug eruption, is to have repeat episodes at the same site. And that leads to the hyperpigmentation clinically that you see is the pigment incontinence resulting from repeated episodes of vacuolar interface dermatitis. So the Other third criteria that I like to look for when I'm trying to determine if we're dealing with erythema multiforme, acute graft versus host disease, or fixed drug eruption is the presence of a mid or deep dermal inflammatory infiltrate. So notice that there are lymphocytic infiltrates around mid-dermal vessels and even going into deep dermal vessels. A couple of eosinophils down here as well. So this is a clue. Here's those eosinophils in those deep dermal vessels. That's a clue to fixed drug eruption as the diagnosis also. So just to summarize, vacuolar interface dermatitis with a superficial patchy lymphocytic infiltrate, an acute cornified layer and an acute silhouette to the epidermis, and your differential for that would be fixed drug, EM, and acute graft versus host. And then to distinguish and recognize it specifically as fixed drug, look for eosinophils, look for melanophages, and then look for a deep dermal component, perivascular inflammation with EOs. Okay, so I am going to move on to the next one. And this is also a punch biopsy. Notice that we have a pretty similar appearing reaction pattern on scanning. A superficial perivascular lymphocytic infiltrate. So we see nodules of lymphocytes around vessels. And above that, in the papillary dermis, we see a patchy band-like infiltrate of lymphocytes. So not a band that obscures and abuts the junction, like you would see in a lichenoid eruption or lichen planus, but a superficial patchy band that you can kind of see through, but nevertheless is in filling that papillary dermis. Again, the reaction pattern here is interface dermatitis vacuolar type. Notice that we have vacuolar degeneration along the epidermal basement membrane. Notice that we have dyskeratotic keratinocytes in the epidermis. Those are the eosinophilic cells with the shrunken and hyperchromatic nuclei. And in this case, it's a little bit more extensive than what we saw in the prior biopsy. So in erythema multiforme, you have, depending on the stage of the lesion that you biopsy, you have varying degrees of dyskeratosis. So think about the dusky targetoid papules of erythema multiforme. If you biopsy the center of a dusky target, you're going to see a lot more dyskeratosis than you are going to see if you biopsy the edge. And just thinking more about it clinically, that central dusky part of the target can detach and ultimately form a blister. And that is just a consequence of the more dyskeratosis that you see centrally. So there's a range of dyskeratosis that you can see in erythema multiforme, ranging from few scattered dyskeratotic keratinocytes all the way to full thickness necrosis of the epidermis if you biopsy the center of an advanced dusky target. We have exocytosis of lymphocytes. So notice that there are lymphocytes in the epidermis. That's called exocytosis, also part of the reaction pattern for erythema multiforme. And again, a cornified layer that's acute. I see retention of dermal papillae and interdigitating rete. So you have a acute silhouette to the epidermis as well. So we're going with our differential again of fixed drug eruption, erythema multiforme, and acute graft versus host disease. To diagnose acute graft versus host disease, you need some clinical information. One clue histologically for graft versus host is when the follicle is prominently involved by inflammation, vacuolar inflammation. So I want to go look for that. In this case, there is a little bit of vacuolar degeneration, but not nearly to the extent that we are seeing in the epidermis. So I would say relative sparing of follicular epithelium here. And then I also look for eosinophils and melanophages in the papillary dermis, and not seeing a lot of eosinophils or melanophages, mostly a lymphocytic infiltrate. And then finally, look for EOs in the deep part of the dermis, and in erythema multiforme, you won't find them. In a fixed drug eruption, they would be present. So this is erythema multiforme. I'm sure some of y'all probably noticed the actual cleft that's developed between the epidermis and the dermis. And this is the consequence of vacuolar interface dermatitis, where the vacuoles actually coalesce. And that leads to detachment of the epidermis, and that's something that you see clinically in one of the targets of EM, is detachment of the center part due to extreme vacuolar degeneration. So this is Erythema multiforme, a part of a papule showing some detachment, and then at the edges still retaining that attachment to the dermis. So that's Erythema multiforme. And just to kind of recap the criteria that I use to distinguish fixed drug and EM, I look for eosinophils and melanophages in the papillary dermis in fixed drug. I look for mid-dermal and deep dermal inflammation, specifically with EOs in fixed drug. And then if I'm going to try to distinguish acute graft versus host disease from erythema multiforme, I look at the hair follicle and look for extensive involvement there. But ultimately, I would rely on clinical information to distinguish acute graft versus host disease from erythema multiforme. Okay, so now I'd like to continue with the differential diagnosis of that reaction pattern, the interface dermatitis vacuolar type, but now moving into connective tissue diseases as sort of a foil to what we just looked at in the more acute eruptions. With the connective tissue diseases, namely lupus and dermatomyositis, being more chronic and hence having a little bit more chronicity evident on the biopsies. So the hallmark reaction pattern for lupus, cutaneous lupus, is interface dermatitis plus a superficial and deep perivascular and periadnexal lymphocytic infiltrate, which is exactly what we see on this punch biopsy. I can tell that this punch biopsy is probably from the face because there's a lot of sebaceous lobules, a dense, there's a lot of hair, vellus hairs, and a lot of sebaceous lobules. So there's a suggestion that this is from the face. I also see solar elastosis, which would further support that. And I see on scanning magnification that there are nodules of lymphocytic inflammatory infiltrates in the dermis, not only in the superficial part of the dermis, but in the deep dermis. And those nodules are centered around blood vessels. Okay, so this is perivascular. And they're also centered around follicles. This is periadnexal. Another candidate for periadnexal inflammation is to look for eccrine sweat glands with lymphocytic inflammation around them. So periadnexal captures the distribution of hair follicles and sweat glands. So it's important to look for that perieccrine and perifollicular infiltrates. So we have a superficial and deep, perivascular and periadnexal inflammatory infiltrate. That should immediately bring to mind lupus on the differential diagnosis. And then we look at the junction of the epidermis and the dermis, and we'll see that there's vacuolar interface dermatitis here as well. So we have vacuolar interface dermatitis along the junction. Notice that in this example of, this is discoid lupus, in this example, there is extreme thickening of the epidermal basement membrane. It almost looks kind of like a worm or a caterpillar that is separating the epidermis and the dermis. That reduplication or thickening of the epidermal basement membrane is a very nice feature for recognizing lupus, most commonly seen in discoid lupus, but you can also see it in subacute lupus. So part and parcel to the reaction pattern of vacuolar interface dermatitis is to find some dyskeratotic keratinocytes. And so you will see a few here in the epidermis in lupus, but it's never to the same degree that you see in erythema multiforme or in a fixed drug eruption. We have more subtle dyskeratosis and vacuolar degeneration. Here's that nice thickening of the epidermal. As lupus lesions become more chronic, you get chronic changes reflected in the epidermis, namely the cornified layer and the silhouette of the epidermis. So The typical cornified layer for lupus is to have compact orthokeratosis. In this case, there's a little bit of parakeratosis, which is also a chronic cornified layer. More common to just see compact ortho. And then the epidermis becomes effaced. Reedy becomes smashed flat, and the epidermis becomes thin. So these are features of chronicity, to see a thinning of the epidermis and effacement of the reedy. Here's some of that nice compact ortho hyperkeratosis. If you find follicles and follicular ostia in discoid lupus, you can expect that they will be filled with keratin. So here's a follicle. Its opening kind of is not, we're not seeing the full ostium or opening of that follicle here in this section, but you can see the hyperkeratosis, parakeratosis that's filling that. That clinically correlates with the carpet tack plugs that can be seen on the if the scale of a plaque of DLE is pulled off with some pickups. And you look at the back side of the scale, you'll see these little tacks or plugs. That represents the follicular hyperkeratosis. Finally, I like to look for mucin in the interstitium in DLE. And this is always something that's kind of I think of on a spectrum. So sometimes the amount of mucin in the dermis is so massively increased that it's just impossible to miss. Sometimes it's increased, but minimally. And mucin is going to be basically a kind of a sandy or granular blue material that separates collagen bundles. And remember that mucin is a normal part of the interstitium in normal skin. And so to consider it a part of the pathology, it needs to be increased rather than just, if it's super scant, then I would not consider that to be increased. In this field, I can see a lot of granular blue material between collagen bundles, and so I would think of this as increased interstitial mucin. Generally speaking, if you have to do stains to even find the mucin, that's not increased to a significant degree. It should be readily apparent on the routine stains. So this is discoid lupus. I like to think of discoid lupus as having the lymphocytic infiltrate, the superficial and deep lymphocytic infiltrate, plus vacuolar degeneration. So it's got those sort of two reaction patterns combined. And then you'd love to see this thickening of the epidermal basement membrane along with vacuolar degeneration. That's just a perfect picture of the epidermis for discoid lupus. One cell type that you really hope not to see in your biopsies of lupus is eosinophils. So if I scan through this infiltrate and I find lymphocytes and some plasma cells, that's okay. If I scan through and find a lot of eosinophils, even maybe just a couple of eosinophils, I need to rethink the diagnosis of lupus, since that's not a typical cell that infiltrates in lupus. Okay, moving on with the same reaction pattern here. This is a biopsy of dermatomyositis. And dermatomyositis is, out of all of the vacuolar interface dermatoses and connective tissue diseases, I think of it as being the most subtle, especially with respect to the degree of inflammation. So this is a punch biopsy. What stands out to me on scanning magnification is the scarcity of inflammatory cells, but yet we have chronicity of the epidermis. We have effacement of reedy, so no reedy ridges here, just total flat effacement, thinning of the epidermis, and even at high magnification, even at scanning magnification, you can see that the reaction pattern is vacuolar interface dermatitis. So vacuolar degeneration of the epidermal basement membrane, a few dyskeratotic keratinocytes in the epidermis, but not nearly as many as you would expect to see in erythema multiforme or fixed drug, and an inflammatory infiltrate which is relatively sparse. So superficial perivascular infiltrates of lymphocytes that are pretty subtle. Some other features that help you recognize dermatomyositis can be remembered if you think about the clinical presentation of DM. And the hallmark for clinical lesions of DM is poikiloderma. Poikiloderma being a triad of epidermal atrophy, telangiectasias, and dyspigmentation. So telangiectasias, you're going to see dilated vessels. Epidermal atrophy is the thinning and effacement of the epidermis. And then dyspigmentation is a consequence of the vacuolar interface dermatitis, and you'll see a few melanophages or melanin granules in these cells around the superficial blood vessels. The main differential diagnosis for dermatomyositis is with subacute cutaneous lupus. Just like lupus, dermatomyositis will have increased interstitial mucin. So how do you tell subacute lupus from DM? That's a difficult one and depends on who you ask. There's certainly a school of thought in dermatopathology that subacute lupus and DM are identical histologically and can only be distinguished on clinical grounds or by correlating with serology. And then there are some, also some who believe that there are a few subtle differences that can help you distinguish. And if you do subscribe to that school of thought, then the telangiectasias are more with dermatomyositis. The interstitial mucin is more with dermatomyositis. The inflammation is less with dermatomyositis. And usually the thinning of the epidermis is more extensive in dermatomyositis. But so it's not a yes or no. It's sort of like parameters or criteria that are more or less. And that's why distinguishing DM and SCLE on a biopsy is so difficult. And I think in practice, it should only be distinguished with clinical correlation and serological correlation. You can favor one over the other on your microscopic findings, but ultimately you need to put that together with clinical and serology to feel confident in DM versus SCLE. And usually clinically they don't pose a big puzzle to distinguish those two. Okay, so the final diagnosis that I think of falling onto this differential is Mycosis fungoides. And so I'm going to show you guys Mycosis fungoides now, which is sharing the superficial perivascular lymphocytic infiltrate and patchy band-like infiltrate with all of the diagnoses we just looked at. And there are some important distinctions though. So the reason that Mycosis fungoides enters the differential diagnosis for connective tissue disease and GVHD and EM and fixed drug is because you have a superficial perivascular infiltrated lymphocytes, you have a patchy interstitial infiltrate in the superficial part of the dermis, and you have lymphocytes in the epidermis. Those lymphocytes will have halos around them, and that can create the appearance of vacuolar degeneration. So vacuolar degeneration of the basement membrane can be tricky if you're just looking for the halos. It's important to look and see if those halos or those holes are occupied by lymphocytes. So in Mycosis fungoides, the holes are not actually vacuolar degeneration holes that have been punched. They are halos around lymphocytes that are infiltrating into the epidermis. So consequently, the holes or the vacuoles will be occupied by a lymphocyte in Mycosis fungoides. Another very important distinction that helps you recognize that this is not vacuolar interface dermatitis as the reaction pattern is the lack of dyskeratosis. So I always say when I'm teaching on this topic is that part and parcel of the vacuolar interface reaction pattern is dyskeratosis, dyskeratotic keratinocytes. So if you aren't sure if what you're seeing along the junction represents vacuolar degeneration or maybe spongiosis or epidermotropism, scan through the epidermis and look for dyskeratotic keratinocytes. You'll see them in interface dermatitis. You will not see them in Mycosis fungoides or in spongiosis. So you want to look through here and look for those dyskeratotics, and you're not going to find them. So then further kind of supporting a diagnosis of Mycosis fungoides, notice how these lymphocytes in the epidermis are concentrated at the basal layer. There are certainly some lymphocytes that are above the basal layer, but most of them are concentrated in the basal layer. That's the preferred distribution for the lymphocytes in Mycosis fungoides. It's called tagging of the basal layer. They line up and enter the epidermis at that basal layer, and then individually may go above, but it's that basilar concentration that's typical of Mycosis fungoides. Notice also that the lymphocytes are present in the epidermis in the absence of spongiosis. So no spongiosis means that you would call this epidermotropism rather than exocytosis of lymphocytes. Finally, notice that the lymphocytes here do not have a normal appearance to their shape. They have irregular nuclear contours. I see some that look bent, some that look notched or twisted, and some that look like polygons. So I want to see lymphocytes that are looking like round dots, not lymphocytes that are twisted, notched, bent, or rectangular shaped. So we have atypia of the intraepidermal lymphocytes, and that's another feature of Mycosis fungoides. The papillary dermis in Mycosis fungoides often has thick collagen bundles. It's described as wiry collagen bundles. And usually the infiltrate for Mycosis fungoides is limited to the superficial part of the dermis. You won't have to interpret immunohistochemical stains for Mycosis fungoides, but I think it's important to know that most subtypes of Mycosis fungoides have an increased CD4 to CD8 ratio. So in an inflammatory dermatitis, CD4 positive T cells outnumber CD8 positive T cells, usually by an order of 2 or 3 to 1. In Mycosis fungoides, the CD4 T cells are increased way beyond that, usually 7 or 8 to 1 or even higher. And then there are some subtypes of Mycosis fungoides that are CD8 positive rather than CD4, namely the hypopigmented variant, and then pagetoid reticulosis in a disseminated aggressive cytotoxic form. But you wouldn't be able to tell anything about CD4 or CD8 without getting that information provided to you or seeing stains on it. But that is Mycosis fungoides. It's a good example of the epidermotropism by atypical lymphocytes. Okay, so moving on, the next part of the differential is verrucous silhouette. So a verrucous silhouette is a silhouette for neoplasms that encompasses exoendophytic profile. So part of the tumor kind of sticks up and part of the tumor can hang down into the dermis, and papillomatosis. So we have a verrucous silhouette here with papillomatosis and exoendophytic profile, meaning partly sticking up and partly hanging down into the dermis. Notice that I see on scanning also some keratin in the epidermis here in what's called the crypt. So papillomatosis is up and down profile to the reedy ridges like a mountain range. Where they go down, that's called a crypt. So this is the crypt here, and notice that bright orange keratin. Also got a few neutrophils in there. That bright orange keratin is a clue to the diagnosis of Verruciform xanthoma. And then looking in the dermal papillae to find the foam cells is how you really secure the diagnosis of Verruciform xanthoma. So Verruciform xanthoma looks a lot like a verruca on scanning magnification, with the exception of this bright orange or bright red keratin that dives deeply down the crypts. That should be your clue to look in the dermal papillae and hunt for foam cells. You find the foam cells there, you've got a Verruciform xanthoma. Okay, moving on to the next verrucous silhouette. This is a tricholemmoma, what some textbooks and some dermatopathologists call a tricholemmal verruca, which is simply a nod to the silhouette being somewhat verrucous. But if you want to use the term tricholemmoma, I think that's probably more universal. And we have some papillomatosis, which is mild, and we have an exoendophytic profile, so partly protruding upward and then partly hanging down with this lobular pendulous profile. Notice that this has a central disorganized architecture, but if we go to the periphery, we're going to see a much more organized proliferation of epithelial cells. Those epithelial cells have some clear cytoplasm. There is peripheral palisading, and they sit on a very conspicuous eosinophilic basement membrane. So that eosinophilic basement membrane outlining the peripheral palisade, and then the clear cells in the middle helps you recognize it as a tricholemmoma. That's tricholemmal differentiation, to have basaloid cells sitting on an eosinophilic basement membrane and then transitioning more towards clear cells centrally. That is a tricholemmoma. What makes this kind of tricky is that the central part has a very disorganized architecture with a dense collagenous stroma. So the tumor breaks up into cords and strands that are smashed between dense collagen bundles. And this is the desmoplastic variant of tricholemmoma, with desmoplastic simply being a stromal response to the tumor where the stroma becomes really dense and collagenous. So desmoplastic tricholemmoma, think of the stroma in the middle of the tumor being really dense and the tumor kind of trying to squeeze between these super dense collagen bundles and having to assume a profile of thin cords and strands to get between those collagen bundles. But if you look at the silhouette, it's got a benign silhouette. It's got a nice lobular, circumscribed architecture, and that peripheral palisade, which can mimic a basal cell carcinoma, but look for the eosinophilic cuticle and that transition to clear cells to recognize it as tricholemmal rather than basal cell. It's a desmoplastic tricholemmoma, and I think that's probably one of the harder cases in this series that we're doing. Okay, next, Verruca silhouette. Exoendophytic profile, partly sticking up, partly going down. This one's on acral skin. Very thick cornified layer. I'm going to rotate this. Let's see. Yeah, here we go. So, papillomatosis, inwardly sweeping rete, which is a nice aspect of the Verruca silhouette also, and a cornified layer that's super thick. That tells us we're on acral skin. Thick cornified layer, no hair follicles, that's acral skin. Here's the Verruca's papule. And as I go in on higher magnification, what is conspicuous is the presence of eosinophilic inclusions in the cell. So the main differential for these very conspicuous eosinophilic inclusions is molluscum virus, molluscum contagiosum, or Myrmecial wart. Myrmecium means anthill, and so it simply describes the clinical appearance of this wart, which is usually on the sole. But a Myrmecial wart has these amazing intracellular inclusions, which represent viral particles. And the big difference with molluscum is the shape of the particle and its relationship with the nucleus. So in a wart, the Myrmecial wart, the particles are very heterogeneous and jagged or irregular. They look kind of like shards of glass. And in molluscum virus, you see a much more rounded, gentle, uniform size and shape particle. In wart, the nucleus retains its shape. It is not compressed or altered at all by the inclusion. In a molluscum virus, the inclusions compress the nucleus to a crescent at the side of the cell. So those are the two features to look for to determine if that is a wart inclusion, a viral inclusion from HPV, or if it's from molluscum. And then, of course, you've got this nice Verruca silhouette, which I sometimes think of as looking kind of like a tulip or a flower with this inwardly sweeping rete and the papillomatosis. Another Verruca silhouette here, this is Keratoacanthoma. So Keratoacanthoma is an exoendophytic tumor that's keratinizing or keratinocytic. Think about the lesion clinically and remember that it has that crater that's filled with hyperkeratosis, and microscopically you see the opening centrally is kind of creating a dell or a pit, and that's filled with keratin. At the edge of the crater or the pit is acanthosis. So we have an acanthotic epidermis. It's essential for a keratoacanthoma, if you're going to make the specific diagnosis of keratoacanthoma and not call it a squamous cell carcinoma, it's essential to see the base and to recognize that the base is very well circumscribed and does not have infiltrating cords and strands or atypical cells. So you've got to see a base like this, which is circumscribed, in order to call it a keratoacanthoma. And at the end of this slide, I'll kind of give you my 2 cents on keratoacanthoma versus squamous cell. But for the strict criteria of the diagnosis, it needs to have a circumscribed base. The cytoplasm of the keratinocytes that make up a Keratoacanthoma is described as glassy and eosinophilic. So abundant, glassy, eosinophilic cytoplasm. Peripherally in the nodules, you have a smaller, more basaloid cell, and this is where it's okay to see a few mitotic figures and some atypia. In a Keratoacanthoma, you often have neutrophil and or eosinophil microabscesses in the epithelium. And another feature that's nice to find in a KA is entrapment of elastic fibers in the epithelium. I didn't see a ton of that in this example. Here's a little bit in this edge here, a solar elastotic fiber. But those are the features that help you recognize it as a Keratoacanthoma. Squamous cell carcinoma would have more atypia and a more infiltrative base. My personal opinion is that Keratoacanthoma is a valid diagnosis that's a little bit different from squamous cell carcinoma because of its indolent behavior and its propensity to autoinvolute. But I think that the criteria need to be applied very strictly to make the diagnosis. It needs to have the clinical presentation. I don't like that diagnosing KAs on the face or the scalp. I think they're better for the extremities. And then you need to have all of the right pathology, meaning a circumscribed and benign silhouette, so circumscribed base, and then that glassy eosinophilic cytoplasm with very minimal cytological atypia. Okay, next is a punch biopsy. Now we're kind of going into some more kind of random diagnoses, which I just thought would be interesting. Punch biopsy here, we have a dermal base neoplasm, which is small, circumscribed. And notice that the epithelium overlying this neoplasm is a little bit different from what you're used to seeing in the epidermis. I see a lot of pallor, and I don't see a cornified layer. That represents mucosal epithelium. Notice also that there's skeletal muscle bundles at the base of the biopsy with this striation. When you combine skeletal muscle with a mucosal epithelium, you're dealing with the tongue as the location. So we know we're on the tongue, and the tumor in question is formed by granular cells. So granular cells here have an eosinophilic cytoplasm, some eosinophilic dot-like inclusions in that cytoplasm. And notice that the cells form what's called a syncytium. A syncytium is essentially like a conglomerate or an association of cells. I know that they're in this little area here in the center of the screen. I know that there's at least 4 cells because I can see 4 nuclei, but I can't tell you the boundaries of the individual cells. The cytoplasm is kind of blurring all together. So that's called a syncytium, when the individual cell boundaries become obscured and they sort of merge. The eosinophilic dots that I pointed out earlier are called pustulo-ovoid bodies. Those are in the condensations of the granules, which are lysozyme granules. So this is a granular cell tumor. Tongue is a great location for that. And then another feature that's nice for granular cell tumor is to see pseudoepitheliomatous hyperplasia in the overlying epithelium. It can even be mistaken for a squamous cell carcinoma or a keratoacanthoma. So that's a reactive change overlying granular cell tumor. Okay. Number 11 is a shave biopsy of a papule, which is ulcerated. And it's got an asymmetric profile, a little bit bulkier on the right side than the left. And what stands out immediately on scanning is this tumor made of basaloid cells forming nodules, sheaths, and some strands in the dermis. It's extending in through the epidermis, which is ulcerated as well. So we've got a basaloid neoplasm forming nodules, strands in the dermis. It's tempting to think about nodular basal cell on scanning magnification, and certainly that would be on your differential, but I don't see the peripheral palisading, importantly. I don't see clefting between tumor and stroma. And as I get on higher magnification, looking at the nuclear morphology of these cells, the nuclei have what's called a salt and pepper or dusty chromatin. So Think about this in contrast to a lymphocyte, which would have a uniform dark chromatin. The nucleus here, this is a Merkel cell carcinoma, by the way. So the nuclear chromatin here, the nucleus is a little bit more opened up. There's some areas that are a little bit light and some areas that are a little bit dark. So it's got a light and dark chromatin, speckled or salt and pepper look. Another feature to notice as you move to higher magnification is that the nuclear shapes are influenced by the neighboring cells. It's called molding. So the cells are conforming to the shapes of their neighbors, and that's called nuclear molding. That's also very typical of Merkel cell carcinoma. Merkel cell carcinoma is going to have frequent mitotic figures and apoptotic bodies, which are basically the dead cells that have cycled through. Here's an apoptotic body here that have cycled through the cell cycle too fast. So this is Merkel cell carcinoma. You would definitely want to work it up before you make the final diagnosis, but the classic immunohistochemical profile to be aware of is cytokeratin 20 expression in a perinuclear dot pattern. So you'll see a little dot next to the nucleus, which is CK20 positive. And you can sometimes see on the H&E stains a perinuclear eosinophilic dot or button. That represents the condensed eosinophilic keratin intermediate filaments, which would stain with a CK20 stain. Sometimes you can see the little buttons or dots without a stain, but you definitely want to get the stain before you sign out your report. That's Merkel cell carcinoma. And finally, we have a punch biopsy here, which has some tissue necrosis, but no inflammation, or very sparse inflammation. This necrotic area is this upper part of the dermis where it's all red. So red is dead. That's necrotic tissue. There's even detachment of the overlying epidermis, which is necrotic itself, presumably due to ischemia. And I'm saying that because the vessels underneath this detached epidermis are all thrombosed. The amount of inflammation is pretty scarce, though, not nearly the degree of inflammatory infiltrate that you would expect based on the severity of the necrosis that we're seeing. And it doesn't take very much scanning in this example to find the fungal organisms here. So there's some here in the middle of the screen. I'm going to go to another area where I think they may be a little easier to see. Okay, so in this area, we see the hyphae. And the hyphae here, some of them are cut on the short axis, some are cut on the long axis. The ones that are cut along the short axis look like hollow tubes or holes, empty holes. And then the ones that are cut on the long axis are these broad ribbon-like hyphae that branch at right angles. So this is Zygomycosis. Another name for this would be mucormycosis. Mucormycosis is a category of fungal infections that includes a couple of different species, one of which is mucor, another one being rhizopus. I kind of like the term zygomycosis because I don't like to say mucormycosis when I don't know if it's mucor or some other organism, but mucormycosis is totally acceptable. But basically the morphology of the hyphae is to be a broad hyaline or pink ribbon-like hyphae that's hollow and aseptate or pauciseptate, meaning no septae or very few septae. And if you see branching, it's going to be at right angles rather than acute angles. The main differential here is with other deep fungal infections like aspergillus, the category that's called hyalohyphomycosis. Those have much thinner hyphae that are septate and branching at right angles. One little clue that I like to look for when we're dealing with zygomycosis is pancreatic, what looks like pancreatic fat necrosis. So you can see these ghost cells and necrosis of the fat because the zygomycosis organisms produce lipase, and it creates a paniculitis-like pattern that resembles pancreatic paniculitis, which you're not going to see in other deep fungal infections. So that is zygomycosis. You'd have to do a tissue culture to really specifically say what the fungal organism is, but this is not aspergillus or candida or one of the hyalohyphomycosis. This is Zygomycosis or mucormycosis. And that is the last case. We've got a couple minutes that if there's any questions, I haven't checked the chat, but I would be happy to look for that. And if anybody has any questions that they want to shout out, my email is travis.vandergriff, so first name dot last name at UT Southwestern. So if you've got any questions, you can also send me an email. That'd be perfectly fine as well. So that is, I think, the last case. And unless there's any questions, we'll end there.
Awesome. Thank you so much, Travis.
Thank you.
Y'all have a great evening.